Good day and welcome. My name is Dr. Shamim Badania from the Leadership Dialogue. In this webinar, we're going to be looking at CoSimPol, the COVID-19 simulator for policymaking. And in this webinar, I want us to look at applying the simulator using some very basic scenarios to look at impacts of different policy options and strategies. In earlier webinars, we looked at the underlying system dynamics model and an introduction to the user interface. So please do check those webinars if you need more information on the actual underlying model itself and the use of the dashboard. Here we'll explore a little bit in terms of scenarios. Just a reminder, you may find the simulator here at this link. And what I'd now like to do is go to the link and let's run a few scenarios. So here's the dashboard, and I've reset the simulation, and that's the base case. To remind you, I've set it up for the base case for South African parameters, and I'm using an R0 of 2.94. And I'm using the number of known cases on the start day of 6,336, which was about roughly a week ago. So using the base case scenario, if I run the simulation, let's see what we see here is that the blue curve is the daily infections, and based on these on this data and these operating parameters, we're looking at about 52 days for the peak infections, which probably takes us to around the end of June 2020. So if we look at the panel here, that corresponds to a significantly high number of deaths of 174,000 people. That's without any interventions. And as we know, in South Africa, we have been in lockdown, and we're now in lockdown intensity 4, level 4. This base case is without any interventions, without any lockdowns. And I'd like us just to explore different kinds of possibilities. So I'm going to use the base case and just run a few basic scenarios with the existing lockdown dates, days, and duration. So if we just work with lockdown 1 with a start of 10 days from the start of the simulation and a duration of 30 days, and if I select low, we will then, let me go live, and you'll see that from none to low, the impact of the lockdown is it's brought the deaths down by a marginal number, and but it's essentially phase shifted the peaks, and it has brought the peaks down a little bit. If I go to a medium intensity, again, we can see the impacts, not a huge difference. High intensity, again, and you notice because of the nonlinear relationships, a higher intensity actually has a slightly worse impact on deaths than the medium intensity. And draconian does almost no difference in terms of the actual impacts on reducing the number of deaths. Now, obviously, number of deaths is not the only criteria, but for the purpose of the scenario, just so that we see the dramatic effect, if any, of lockdowns, I'm focusing largely on the number of deaths. Now, what I'd like to do is I'd say none, and I'm going to go to lockdown intensity 2. If we go to low, you now start to see some difference. And what's happening here is we've brought the deaths down by some 40,000, and so this is with a fairly low intensity. So we're already starting to see some impact of lockdowns. If we go to medium, that's brought the deaths down even further. And essentially what we're doing is we're shifting the peak, and we're changing the intensity in which the epidemic is allowed to slow down and then pick up again. Let's go with the lockdown intensity of high, and we've brought down the number of deaths with the lockdown intensity of high brought it down by probably about 100, just about 90,000 odd. So that's just with lockdowns without any additional non-pharmaceutical interventions. And the non-pharmaceutical interventions would be things like the use of personal protective equipment, masks, social distancing, hand washing with soap, etc. So if I turn that switch on, you'll see the contribution to that. And so now we've brought the deaths down by even more, and it's shifted the peak curve. Let's go to the breakdowns, and that will give you a slightly better sense of what's happening in relation to the impacts of these two strategies. So here we have a lockdown intensity 2 of high, and we've turned on the switch for non-pharmaceutical interventions. If I go back to the infection spread, and I now look at the dial and quality of in-hospital care. So what's the dial on number of deaths? And if I turn that to 10, we've essentially taken away most of the deaths. So what this is modeling is the quality of care in hospital, and it's a nonlinear relationship ranging from 1 to 10, and 10 essentially means almost perfect healthcare, and that's again unachievable, but it gives us a sense of the kinds of ranges. So this is probably the best result we could achieve with these three interventions of a lockdown, non-pharmaceutical interventions, and improving the quality of healthcare. But we do know that lockdowns also have a whole lot of adverse effects, and we need to also look at, if I take down lockdown 2 and I go back to lockdown 1 and go high, you'll notice that's now taken us to 80,000, added another 80,000 odd deaths. And so we have to ask the question, why is this happening? And the key lesson here is that lockdowns can be effective, but they can also be damaging, and they're effective if we get the timing right. So lockdown 1's timing is way too early. Lockdown 2 in this scenario is we're getting the timing better to be able to have that impact. So the important lesson is we have to be very good on our timing. The question is, what is that timing? And the timing means we need to get the lockdown as close to the peak infections as possible. The problem is there's no way to measure that, because we actually don't know when we're hitting the peak. So that's going to take a lot of effort in terms of measurements and understanding and analyzing the numbers as the infection spreads. Okay, so now let's do another kind of set of interventions, is that if we're unable to get the timing of the lockdown right, and we know that the lockdowns have all these adverse impacts in terms of mental and well-being, impact on jobs, impact on food security, because high levels of lockdowns have those adverse societal effects. And there have been many arguments against lockdowns. So the question becomes, if we don't have lockdowns, or we have relatively low intensity lockdowns, they're not having as significant an impact. If I go back to the base case and I go to a lockdown intensity of low, we still have a significant number of deaths, and we still have a fairly high peak infection ratio. That gives us a sense there. So the next question becomes, how else could we engage with mitigating the effects or reducing the impacts of the epidemic? And the other area is in relation to bed capacity. So we know large numbers of people would recover from COVID-19 without requiring hospitalization, and some have used estimates of almost 80% of prevalence would face that. The question becomes, what about those that do need hospitalization and we don't have sufficient capacity, which is why we are getting to these high numbers of deaths. So in addition to the quality of healthcare, it's actually the capacity of healthcare. And CoSimPol has capacity models both normal hospital bed capacity as well as critical care bed capacity. So that would include things like ventilators and so ICU capacity, etc. So we could do a little bit of an experiment and say, well, okay, let's suppose we didn't have any lockdowns. What would be the requirement in terms of bed capacity? So if we go to this tab here, on hospitalization, what you'll see is the orange tells us our current hospital bed capacity, and the figure to focus on is the green on severe cases not hospitalized, because that's essentially telling us where we lack the number of beds at the time that we need it. So we may have beds available, but not at the time of at the peak times. So it's this little green curve here, and you'll see that on day 69, severe cases not hospitalized is 6,290 odd. Remember, that's a daily requirement. So if you look at the area under the green curve, that's essentially a big contributor to the number of deaths as the epidemic runs its course. So one way of dealing with this is to say, well, let's try and figure out what the bed capacity ought to be. So firstly, let me put the quality of in-hospital care to 10, so that uses up all the contribution from quality of healthcare, and that brings the deaths down from 174,000 to 146,000. And then let's apply the non-pharmaceutical intervention, so that brings us down to 80,000. So essentially, those 80,000 deaths are primarily as a result of the vulnerable and the ultra-vulnerable contributions of the population of prevalence. And the only ways to bring that down, apart from lockdowns in the current set of scenarios, is to increase the bed capacity. So to be able to ramp up bed capacity. And one of the strategies that the government is using is field hospitals. So this would be such an example. So how would we know what that peak bed capacity is likely to require? So we could just experiment a little bit. We could do this mathematically, but using the simulator, if I take that from 125,000 to 160,000, and I tab, and you'll see that we've brought the deaths down quite significantly. So, and now you will notice that you can almost barely see the green curve. So we've now almost essentially eradicated the contribution of lack of bed capacity. So if I now take it down to 150,000, you'll notice that there is a small dent on the green curve. There is a little bit of a peak. So we know that we're sitting somewhere between 150 and 160,000. So let's go 155,000. And we still have a bit of a number there. So we're just going to experiment a little bit. Let's make that 157,000. And essentially, we're starting to see that roughly that's the kind of capacity, probably 158,000 is the bed capacity that we're going to need in relation to normal bed capacity. But we still have these deaths of 16,400. And that contribution is coming from insufficient. If we go to the critical care, you'll notice that there's a similar parallel case to normal hospital beds. And here we are looking at severe cases is the red curve. And remember that 344 that you're seeing there, as I move my cursor, 352, that's on that particular day, on day 88, there were 352 patients that required critical care, and there was just not enough bed capacity. And so just think of the scenario in Italy where people were dying because there was insufficient ventilators. We're modeling that now. Now we're looking at that type of scenario. So on day 88, we had 352 patients that required critical care. We just didn't have the capacity, and therefore those patients are going to die. And that's what's contributing to the current 16,400 deaths in the panel here below. So what would that capacity need to look like? And again, we could run a similar kind of sets of experiments if we up that to say 6,000 beds, and you see that the red curves come down, but they're still, it's not sufficient. So we could experiment, run that to 8,000, and that's essentially taken away the red curve, which means that we now in the order of having the right level of critical bed capacity. Where does this contribution of 5760 come from? Well, essentially that's coming from the ultra vulnerable per thousand probably that just simply do not have opportunity to get to hospital. And if we remove that, that comes down. So we can now start experimenting in relation to bringing those number of deaths down. All right, so here we've just run a few basic scenarios. We could, excuse me, we could run a whole set of other scenarios and sensitivity analysis just to see the types of interventions. So now if we go back to the bed capacity, the question becomes, that's the peak bed capacity, but are we going to be able to ramp up, and what kind of timing? So this just helps us identify what the peak bed capacity would need to be able to reduce the number of deaths and to manage the epidemic. So what we have here is the simulator enables one to kind of model the ramping up of building of beds. So let's go to hospitalization. Now you'll notice that the orange line is, whereas we started off, it was at 125,000, you now see the ramping up, and that ramping up is as a result of this kind of ramp up shown here. So as the user, one could model what the practical capacity, the practical flow in developing field hospitals might be. And that's where we would do that. So we would reset the simulation, go to our standard base case in terms of bed capacity, and then we would have to be able to ramp up to see the effects over what time period we would be building up the necessary bed capacity to be able to have the necessary impacts. So the other way of looking at it is that it takes time to ramp up to bed capacity. So you probably want a combination. If we go to this curve on the infection spread, and let's reset the simulation to base case, run the simulation. And so this says, look, the peak's going to be around day 54, but are we going to be able to ramp up sufficient bed capacity by that time period? And how do we keep things contained? And so one way of doing that is say, okay, let's now put in a bit of put in some lockdowns that would then delay, to some extent, delay the curve. Let's go live. So we could go to lockdown 1. Let's remove lockdown 2. So what we've done is we've moved it to day 69 from day 50 odd. We go to a medium lockdown, it phase shifts it more. So that gives us probably, from the base case, that gives us roughly another 2 months to be able to ramp up bed capacity. So you would then do a combination of lockdowns and bed capacity to be able to look at the impacts. And so on, and that's how one would explore a range of scenarios to have the necessary impacts, together with things like non-pharmaceutical intervention. So that in this particular case, what we've done is we have a medium lockdown to delay the peak. It gives us time to build hospital and bed capacity and critical care capacity. We improve the quality of in-hospital care and non-pharmaceutical interventions to be able to reduce the number of deaths, reduce the adverse impacts of the epidemic. I'd like to now just very quickly just reset the simulation and have a quick exploration of, on the base case with an R naught of 2.94. If we go to this tab, essentially we're seeing that given that value of R naught, not everybody gets infected. So we actually have a healthy population of about 3.67 million, which in a sense says there is a kind of natural herd immunity with this value of R naught without a vaccine. And that's quite interesting, and that would need a bit more interrogation and exploration. But the hypothesis would be that we actually can get a natural herd immunity if the R naught is small enough. And let's just look at what the impact would be if we went for, go live, if we went for a high lockdown intensity, lockdown 2, and you'll see that we're now sitting at 10.7 million that actually don't get the infection at all. So there are elements of herd immunity with the right combination of interventions. So that gives us a sense of some basic scenarios. There's many others that we could run, and perhaps in future webinars we will explore those. But I think with the three basic webinars we've had now, as a user, you ought to be able to find comfort in using the simulator, in testing hypotheses, in testing interventions, in critiquing the parameter values and changing the parameter values to be able to validate the model for yourself. I've set the base case for South Africa, but you could apply it to any other country or even a local context. So that gives us enough. So we've had the webinar that talks us through the basic structure of the model, the underlying system dynamics model. We've had the webinar that explains the dashboard, each of the tabs and how to use it. And now we've had this webinar that runs some basic scenarios in different kinds of interventions and their impacts. And I trust that that is sufficient for you as a user to be able to build confidence in using the model, to interrogate the data, to interrogate the numbers, to check the hypotheses in the underlying model in the base case assumptions, and one could test those, interrogate those, and most of these you can change to the values that make sense to you, that you think is validated by exploring with the different experts. So thank you very much. That's the actual simulator itself. If I just go back here, and we can see that that's where you would find the actual simulator itself. So thank you very much, and we'll see you next